Want to introduce Dr. Spitters. Most of you know him. His talk is titled Isolation of Pulmonary TB Patients, Updating the Framework. Dr. Spitters is the medical consultant for the Washington State Department of Health's TB program, and he's been a tuberculosis medical officer with the Snohomish County Health District. Since coming to Washington State in 1994, he has worked primarily as a TB clinician, TB control officer, and/or health officer for King, Snohomish, and Yakima counties. He also served in similar roles of shorter tenure for Island, Chelan, Douglas, Pacific, Atherton, and Pierce counties. He's been board certified in general preventive medicine and public health since 1994. He is a clinical professor in the Division of Allergy and Infectious Diseases at the University of Washington School of Medicine, and is a lecturer and regular warm-blind medical consultant for the Curry International Tuberculosis Center at the University of California, San Francisco. His personal interests include spending time with family, physical fitness, sports, listening to and playing classic rock music, which I did not know, and I'm going to ask him about later, and travel. Along with Dr. Narita, on a personal level, Dr. Spitters and Dr. Narita basically taught me everything I know about tuberculosis, and I'm very happy to have him as our Washington State medical consultant. Without further ado, please take it away, Chris. Actually, before you do, I just want to say a few things. So we've had a bunch of questions about these new guidelines coming to our ECHO panel and community, with some people, very, very happy about the new guidelines and saying it's about time. Patients with TB have been kept in isolation for too long, and then some patients on the other end of the spectrum being concerned about them, mostly out of respect for the bug, because they've seen what it can do to people. And I think there's going to be quite a spectrum on this call. I hope this is a cordial discussion, and I hope that it's helpful for everybody to kind of come to some consensus so we can address this going forward. So please take it away, Chris.
Fantastic. Thank you so much, Bijan, for the kind introduction. I promise not to pick up the guitar while we're talking. I'm going to try to share my slides now so you can all see them. And can I get a signal that you can see the slides now? Okay. And you can hear me all right. So great. All right. So here we go. Good afternoon, TB ECHO participants. I'll be speaking to you today about the NTCA's recently released guidelines addressing isolation of people with pulmonary TB. I will confess I find this somewhat of a formidable task, summarizing and commenting on the work of others more versed than I am in the underlying evidence base. But hopefully this outsider's view and discussion of the guidelines that will ensue will inform your own reading of the guidelines, which I highly recommend, and how to choose and how to frame your own review and reconsider your isolation practices in your setting going forward. Disclosures: I have no financial or other conflicts affecting the material presented today. The comments I will be making are targeted to Washington State clinicians and TB cases, although hopefully relevant for all of you. For those of you participants who are not working in Washington State, please consult your local or state health department for isolation policy guidance in your jurisdiction. And last but not least, my comments today are my own and do not necessarily reflect the formal policy of the Washington State Department of Health, which is formation of that policy is underway, and this is part of it. So without further ado, let's take a look at a scenario for consideration. And that's a 43-year-old healthy hospital food service worker who arrived 3 years ago from a high-incidence country. On pre-employment screening, the worker was asymptomatic but had a positive QuantiFERON, had a benign past medical history, no TB history. The chest X-ray showed modest non-cavitary right upper lobe scarring. Sputum smears were negative. The one PCR done was negative. That's an error on the slide. You cannot detect or fail to detect a RPOB mutation if there's no PCR positivity, because there's nothing to bind. So just PCR and smear negative, asymptomatic, healthy hospital worker with a positive QFT and some right upper lobe scarring, and cultures are pending. So that person went back to work And about 5 weeks later, everybody gets a phone call saying that 2 of 3 cultures yielded MTB at 35 days incubation. Phenotypic drug susceptibility testing results were pending. Patient was sent home from work and now is sitting in front of you in an isolation room, ready to start treatment and asking, how long will I be isolated and when will I be able to go back to work? So I'm going to hand that now over to Vita, and if you can put up the poll for how to approach this. So potential responses would be no isolation. We'll start treatment today, and tomorrow you can go back to work. Alternatively, well, you're okay to wander about and do your regular thing outside of work beginning tomorrow, but you can't go back to work in a hospital for 7 days. Or let's just tell you that 14 days of treatment, you got to stay home until then. And then after that, you're good to go. You can go to work and do whatever else you want. Or maybe we ought to wait and see what the drug susceptibility test results show and keep you isolated until then. So please have at it. And Vita, let us know when we hit say the 50% mark on participants.
We are at 46% participation. Oh, we're still climbing. 55% now.
Well, hopefully that's a representative sample, and not to cut off those of you who haven't responded, but kind of to keep the flow going. I'd say if you can capture those results, Vita, and share them.
Sounds great. I'm going to end the poll now and showing the results.
Okay. So as I was expecting, and as I think Bijan previewed, there's a diversity of views and experience and approaches on this, and we see a fairly broad distribution of responses, with the lowest response being no isolation at all. Okay. So let's close that one and move on to the next. Can you see scenario 2 on the screen, folks? Okay, great. So this one is a patient at the other end of the disease burden spectrum. Same age. This is a self-employed housekeeper, works in people's homes, not in a hospital. Living with a family of 5. She's the sole wage earner in the household. She's been sick for 3 months with a typical TB-like illness. And on chest imaging, she's got extensive bilateral cavitary disease with endobronchial spread to all lobes. She's then starts therapy. And so now here we are a month later, fully adherent, tolerating meds. The TB program has been subsidizing her rent and groceries and some utilities bills while she's been in isolation. She's feeling a lot better, much better, almost, kind of functionally back to baseline, and has gained back some of the weight she lost. And now DST results come back, and they're fully sensitive. But her last 3 sputum smears are variable, but still positive. Improved from baseline, which is they were mega 4+++, and now they're variable at an intermediate level. Cultures are still growing in 1 to 2 weeks, and she wants to go back to work, but you haven't gotten any phone calls yet from administration about the subsidies that are going to her, and you're trying to decide what the right thing to do is. So Vita, can you show us the options on this one? So, well, let's continue isolation until smear or culture negative. That way, we have maximum assurance, we think, that there will be no risk of transmission to others. How about letting her out to go to the grocery store, go to the bank, what have you, with a mask on, try to keep the visit short, do what's necessary, and can visit with previously exposed friends and family, but otherwise no housekeeping and no congregate settings. Next option is all those liberties, plus she can now go work as a housekeeper again, back to her clients, but no congregate settings. Or alternatively, you can flip that and say, well, you have all the, all the most urgent liberties, and you're okay to go to congregate settings, but you can't be going into people's homes to clean. And then last but not least is, no, you're good, released from isolation, you can do whatever you got to do. Okay, so let's see what folks, where we land there.
Okay, ending the poll now.
Okay. All right. So, and the most frequent response here reflects what I'll share in a moment, that we think is the prevailing practice in Washington State, that such a patient would continue to be isolated until smear negative, or again, in heavy burden patients like this, a lot of times they're expectorating dead organisms, and so you actually get negative cultures before you get negative smears. So that's the most common answer. The least common answer was okay for congregate settings. And the other two were intermediate. So this, we're going to revisit this later. And so if I may proceed, do I click that box off, or you've got it? There we go. Thank you. And let's continue on. So this leads into what our learning objectives are today, which briefly are to describe NTCA's 2024 guidelines for respiratory isolation and restrictions, to recognize clinical epidemiologic setting, that is environmental, and policy factors that may warrant a more cautious or gradual release from isolation, and to identify resources for consultation in difficult or ambiguous cases. Okay. Well, in the interest of reassessing the basis for isolation restrictions and reconsidering the balance between impositions and costs imposed on the patient with benefits accrued by society at large, the NTCA has issued these guidelines. Their work on the topic and the guidelines culminated in has prompted us, the DOH-TB program, and I presume all of you, to reconsider our guidance for the use and duration of isolation restrictions in community settings. This talk reviews those guidelines in broad brushstrokes and explores factors to consider in their implementation in Washington State. As a point of departure, let's read this excerpt from an invited commentary accompanying the guidelines that was written by CDC Division of TB Elimination staff. Many public health TB programs, extrapolating from national healthcare facility guidelines, have required that individuals with TB have negative AFB sputum smears prior to discontinuation of isolation in community settings as well. It's not unusual for persons with TB, particularly those with extensive or cavitary disease, to have persistently positive sputum specimens for weeks to months, as we saw in the second scenario we just shared. This level of control, if you will, is more restrictive than the criteria for determining non-infectiousness that was set forth in CDC's 2005 TB control statement, but it remains a common, if not the most prevalent practice among TB programs. The primary principle set forth in the NTCA guidelines is that although sputum smear grade and cavitation on chest radiography are correlated with pre-treatment infectiousness, sputum smear status appears to be dissociated from capacity to transmit once effective treatment has begun. And it is the duration of treatment that determines ongoing infectiousness. Based upon a constellation of observational epidemiologic studies, bench research involving gene expression among TB germs exposed to anti-TB drugs, quantification of viable mycobacteria in the aerosols of treated patients, and animal studies comparing acquisition of TB from human cases before and after initiation of effective therapy, The NTCA writing group concluded that most patients, even those with high disease burden, become non-infectious within several days of starting and adhering to an effective regimen. This table from the guidelines indicates the recommended degree and duration of isolation in community-based settings based on pre-treatment bacillary load, that is high versus low, and duration of therapy, less than 5 days versus more than 5 days. As you can see, these guidelines discourage continuation of isolation for most cases after 5 days of effective therapy, even if pre-treatment bacillary load was high. The recommended shortening of proposed isolation period for most cases to just 5 days represents a substantial reduction from the current prevailing practice for smear-positive patients, which, just to reiterate, has generally been 14 days of treatment plus any additional time needed to become sputum smear negative. In parallel, NTCA recommends against the routine use of sputum smear status as a tool for setting the duration of isolation in community-based settings. They also recommend that expert consultation be pursued when isolation in community settings is extended beyond 14 days. Exceptions and caveats to this newly proposed approach are many, but a key one is that longer isolation periods can still be considered for patients whose response to therapy may be less swift. For example, very heavy pretreatment disease burden, severe immunosuppression, malabsorptive states, non-adherence to DOT, or clinician uncertainty about the effectiveness of the regimen. Release from isolation can also be implemented in a more cautious manner when the liberated patient would be returning to a crowded or poorly ventilated workplace or living situation, exposing children under 5 years old, exposing immunocompromised people, or planning to travel by public conveyance. These guidelines do not apply to healthcare settings, homeless shelters, correctional or detention facilities, and analogous congregate settings. They also do not affect worker protections and employer duties with respect to adhering to existing laws, policies, guidelines, and best practices for preventing TB transmission in the workplace. Now, this gap between NTCA's and others' guidelines may lead to awkward moments with patients and community partners when TB patients are addressed differently across settings. To the casual observer, and possibly to some more informed observers as well, these differences may seem odd and likely to present implementation challenges. Considerable education and day-to-day dialogue between TB programs, their staff, patients, families, and other community partners will be necessary to explain and reconcile such differences where these guidelines are implemented. This table, I forgive the busyness of it. I'll focus our looking at it in just a moment. It summarizes the criteria for release from isolation set forth in different sets of guidelines and offers a cautious and pragmatic adaptation for TB programs in Washington State to consider in the column on the far right. Moving from top to bottom, each successive row shows an increased increment in pre-treatment transmission potential. Moving from left to right, each successive column shows a less imposing duration of isolation. First, CDC's healthcare guidelines, which are most strict, then CDC's 2005 TB control statement addressing when patients can be considered non-infectious. Third column, the NTCA guidelines. And the last column represents draft considerations for a cautious implementation in Washington State based not only on the NTCA guidelines, but also on other guidelines, consideration of health officers' legal duty to protect specific individuals and settings, and a margin for error given remaining gaps and uncertainties in the evidence base. As an example, let's look at the second to last row, patients who smear 2+ or greater and cavitary, where following the healthcare guidelines can lead to isolation periods of up to several months as we wait for smear or culture negativity to emerge. following the 2005 control statement's release from isolation criteria could lead to an earlier release of many of these patients who are improving after 2 to 3 weeks of therapy. And the NTCA guidelines would generally release most or all such patients after 5 to 14 days. In the final column, our draft consideration is to release to low-risk settings after 14 days, with an extension up to 28 days for higher risk settings. Thereafter, many persistently smear-positive, heavy burden cases who are nevertheless improving clinically and have a fully sensitive organism could be released to most or all non-congregate settings prior to becoming smear or culture negative. This table shows the observed distribution of severity of disease at diagnosis during an average year in Washington State across the rows or down the rows from top to bottom. The columns from left to right, show the number of estimated person days of isolation occurring under current practice for each row. With our current practice, on the left, the NTCA guidelines in the middle, and then the more cautious approach on the far right. Under current practice, we estimate that just over 4,000 person days of TB isolation are occurring in Washington State during an average year. Not unexpectedly, more than half of those days are attributable to patients with smear-positive cavitary disease, a group which currently experiences isolation periods with a median duration of 6 weeks. We estimate that the most ambitious implementation of NTCA's guidelines would reduce estimated cumulative person days of isolation by 86% among a typical annual cohort of TB cases in Washington State, down to just under 600 person days statewide. A more conservative or cautious approach to implementation would still yield a 45% reduction in person days of isolation, down to about 2,200 days. Note that almost 50 to 60% of the reduction in total isolation days in either case is anticipated to occur among patients with the heaviest pretreatment bacillary loads. By avoiding such lengthy isolation periods among these heavy burden patients whose infecting organism is drug sensitive, who remain adherent to treatment, and who are improving clinically after 2 to 4 weeks of therapy, most of the anticipated population benefit from these guidelines can be achieved without any additional effort. Meanwhile, through patient education, high-quality case management, and continued use of targeted material support for patients undergoing shorter isolation periods, TB programs can mitigate the relatively smaller costs and harms imposed upon this group of patients as well. Eligibility for release from isolation includes the following criteria. First, the patient's on a regimen deemed to be effective. A common definition for likely to be effective while DST results are pending would include no prior episode of treatment for active TB, not a known contact to MDR TB. If an expert was done, there are no RPOB mutations, and the patient is on 4 drugs to which the organism is known or likely to be sensitive. Now, the NTCA guidelines did not specifically address the role of isoniazid resistance, which is present in 10 to 15% of new cases. Isoniazid plays a key role in the early bactericidal activity during the first few days of anti-TB therapy. However, isoniazid susceptibility results typically are not available for 4 to 6 weeks. Consequently, availability of rapid molecular results for both rifampin and isoniazid resistance mutations would further increase confidence in determining that the initial regimen is indeed effective. Second, adherence with in-person directly observed therapy during the period of isolation. I would suggest somewhere north of 90% adherence to Monday to Friday doses administered, and having the patient make up any missed doses. So going by doses, not calendar days. Third, clinical improvement has been objectively demonstrated prior to release from isolation. For example, fever resolved, cough reduced, sputum production reduced. Fourth, upon release, no ongoing exposure will occur to immunosuppressed contacts or children under 5 who are not on window prophylaxis after release from isolation. Such contact with these most vulnerable folks should be avoided until smear negative ×3 or culture negative ×2, whichever comes first. Additional congregate settings which warrant, oh, I'm going to go back a second, forgive me. Just wanted to state that congregate or high-risk settings for which previous guidelines should be followed include, but may not necessarily be limited to, healthcare, homeless shelters, and correctional or detention facilities. Healthcare settings include, but are not limited necessarily to, inpatient facilities, outpatient clinics, kidney centers, long-term care, and pharmacies. Additional congregate settings which warrant consideration for more conservative release from isolation include, but may not necessarily be limited to, primary and secondary schools, other educational settings, childcare, group homes, dormitories, and public transportation. Note that WHO guidelines appear to restrict sputum smear positive patients from boarding commercial aircraft, and CDC staff's commentary on the guidelines also mentioned caution with respect to public conveyances. Furthermore, outbound travelers who are still smear positive who successfully leave the country could theoretically have difficulty re-entering from abroad prior to meeting DGMH criteria for entry, although it's not clear to me that DGMH would become aware of such circumstances if they were to occur. Last, when considering the population into which a patient will be released, remember that an estimated 1 in 15 people, about 7% of the general population, is immunosuppressed. Last, please note that airborne isolation restrictions for TB do not generally apply to uncrowded outdoor settings where close contact with others is avoided. Okay. So why don't we go back to our first scenario and take a look at that. And you'll get another chance to cast your ballot. And again, this is, I'll speak as we go. Again, like most of the questions we pose on ECHO, there's no correct answer really. I'm looking more for what impact this information might have on your view that you expressed earlier.
Here we are at 30% participation. Okay, we are at 60% now, so I'm going to end the poll.
Okay, so we see a little shift in the distribution. No, very few people are ready to let her go back to a healthcare facility to work the next day, and that would be consistent with the healthcare facility guidelines. We really can't, that's a little too soon, even for a smear negative patient, which generally 7 to 14 days of therapy, depending on which guideline, which CDC publication you look at for smear negative cases. Because remember, those healthcare facility guidelines apply not only to the customers, but to the service providers as well within the building. And so we see those two middle road approaches getting the most coverage, and only a small minority are either willing to release right away or further isolate until DST results become available. All right, well, let's move on. We'll come back to the second one a little bit later. I just want to continue on with some other comments. Many patients may be eligible for graded restrictions at the outset of therapy and during follow-up on treatment. And by graded, I mean it's not all or nothing. Either you're isolated to your home or you're free to go everywhere. There are intermediate liberties that many TB patients, especially as TB therapy progresses, can be granted. For example, a patient with low bacillary load, like the first scenario, might still be allowed to go to the grocery store while wearing a mask and keeping the visit as short as possible, even during the initial days of therapy. Conversely, with a patient with a heavier pretreatment bacillary load, like the one we're going to revisit in a moment, may be released for certain activities like grocery shopping, other essential errands, visiting with previously exposed contacts, while continuing to temporarily forego other activities like singing in the choir, working in a crowded, poorly ventilated work setting, working in healthcare, or attending an indoor gathering out of their home. Such layered accommodations are granted at the discretion of the local TB control officer and can be used to reduce negative impacts on the patient. Partial restrictions can help cultivate adherence while still preserving our interest in preventing transmission in higher risk settings. While objectivity and fairness in offering such graded restrictions across patients is expected, it also seems reasonable and practical for TB control officers to consider the patient's willingness and ability to comply with complex or nuanced directions. Whoops. Although the curve of adoption remains to be seen, these NTCA guidelines would seem to offer a new standard for the minimum duration of isolation. Given ambiguity, at least in my mind, in the formal adoption or endorsement of these guidelines by CDC, gaps in the underlying evidence base, and the fact that legal powers and duties for public health management of TB cases and protection of others rests with the local health officer, it remains the local TB control officer that makes and enforces isolation policies within their jurisdiction, albeit with this guidance and its underlying principles in mind. The NTCA guidelines do not address risk management and legal compliance concerns that may arise and which would be mitigated by CDC's endorsement or, for that matter, modification of these guidelines. In Washington State, local health officer duties related to TB control, as set forth in State Board of Health rules in the Washington Administrative Code, define American Thoracic Society, ATS CDC statements as the source for establishing treatment plans, of which isolation is a component. Last, some terminology in the guidelines comes across, at least to me, as vague. For instance, the guidelines state, while there is no definitive duration that reliably predicts non-infectiousness, 5 days of anti-TB therapy is expected to reduce infectivity to low levels in most instances. Well, what do low level in most instances mean? Much lower than before treatment? Of course, but is that lower level and the ambiguity in defining it acceptable to local health officials and to the communities into which the patients will be released? A few suggestions for your consideration. Remember that patients with certain characteristics may merit a more cautious release from isolation because their response to therapy may be slower than the general population of active TB cases. Examples of such include, but are not necessarily limited to, severe immunosuppression, conditions associated with inadequate drug absorption. Local health jurisdictions may consider additional factors when considering total or partial release from isolation, especially among patients who have heavy pretreatment bacillary loads. Examples include the availability of drug susceptibility testing results, the density of people in the setting to which release will occur, the health status and susceptibility to TB infection of other members in those settings, the airspace and airflow characteristics of the setting, and the patient's willingness and anticipated reliability in implementing any additional non-pharmaceutical interventions the health officer directs for that setting. Examples would be time limits, wearing a mask, not smoking. Consider seeking expert consultation when planning to continue isolation beyond 28 days. I say that rather than 14, just to manage the volume of potential consults that would arise, and also to align with the more cautious approach recommended in the last column of those tables I showed you. Be alert and respectful of interjurisdictional issues and potential conflicts that may arise. If a patient is released from isolation by LHJA and intends to resume activities like work, school, legal obligations, social or family visits in LHJB, LHJA should notify LHJB in advance to discuss the case and the basis for release from isolation. Toward this end, as Bijan mentioned in the introduction, harmonization of release from isolation across LHJs is encouraged. However, in the end, the authority to approve such activity in LHJB is at the discretion of the LHJB health officer. Analogously, release from isolation by an LHJ does not commit healthcare providers, employers, educators, shelter operators, or analogous entities in the community to engage the patient without exclusion, restriction, or special handling based on their infection prevention policies. In many cases, CDC guidelines or their organizational policies for their specific setting will indeed call for a longer period of exclusion or special handling. In other lower risk settings, education of a reluctant community partner may assist them in harmonizing their approach with that of the LHJ, if appropriate, and at their discretion. All right, so let's go back to scenario number 2 and see what you think about that one.
Okay, we are at 30%. Okay, we have reached 50%, so I will end the poll.
Okay. All right, so again, you know, like in the general world out there, in response to these guidelines, there's still a diversity of sort of comfort and uptake with the shorter release times. Most of us, I think, now would looking at that first line, I think that's maybe the most important thing I've seen is we went from 42% down to 10% who would still hold this patient, you know, in sort of total isolation. And most of us are willing to give at least some you know, necessary low risk liberties, and about a third of us would be, you know, willing to just let them do their thing. Okay, so let's move on. In the interest of time, I'm not going to review in detail the other CDC guidelines applying to congregate settings, but these slides that you'll have access to cover that. And the basic theme in healthcare, corrections, and shelters is 14 days of therapy, improving, and smear negative. With some variation, slight variation, but that's the gist of it. Trying to get back to my comments here. All right. I want to make a comment here about evaluation. While societal risks from implementing these guidelines are deemed to be low to nil by the NTCA writing group, evaluation of the impact of this transition in practice seems quite worthwhile given the gaps and uncertainties in the supporting evidence base and our lack of programmatic experience with this less restrictive approach. We will look to CDC and academic researchers for post-implementation evaluation, but in the meantime, we also ask all of you in Washington State to report to us any scenarios where use of the new guidelines is associated with suspicion for post-release transmission by a liberated patient. So in summary, the NTCA guidelines endeavor to reduce the negative impacts on pulmonary TB patients while trying not to adversely affect the incidence of TB in the community. In addition to keeping an eye on TB incidence at the macroscopic level, local health officers also have to consider their legal and risk management obligations, like the duty to protect specific individuals and settings at the micro level. The guidelines recommend that isolation be used more judiciously than has been common practice in the current era, that isolation restrictions be graded based upon risk of transmitting rather than all or nothing, and that most patients can be released after 5 to 14 days of treatment, regardless of sputum AFB smear results, which, by the way, NTCA recommends not be used as a tool for release from isolation. So what do we do now in Washington State as public health practitioners? Well, over the coming weeks and months, DOH will receive and process partner feedback and update the clinical guidelines that we offer accordingly. In the meantime, and I would say thereafter, for that matter, the most efficient application of these guidelines would be to start with releasing persistently smear-positive patients from isolation who have been on therapy for more than a month, who are adherent, tolerant, improving clinically, and who are known to be on an effective regimen as validated by DST results. As stated earlier, more than half of the maximum reduction in person days of isolation can be achieved with this single consideration. LHJ TB control officers and other local TB control staff should be clear with patients that the end of isolation is not the end of a patient's obligation to adhere to the treatment plan and to otherwise cooperate with reasonable directions and requests toward that end. Exercise caution with release of patients with concerning clinical features discussed earlier and with high-risk contacts and settings. Seek consultation from the DOH TB program in difficult or ambiguous situations. You can also propose to bring a case to TB Echo to have it discussed. And then, of course, we have the Curry International TB Center warm line. I will let you know, we've asked them to let us know when they get consultations about isolation, just so we can kind of keep an eye on things and know what the pulse is out there in the community. And last but not least, as before, determining the need for, nature of, and duration of isolation will remain the domain of the local TB control officer. I'd like to recognize the hard work of the NTCA team that worked over 2 to 3 years, I think, drafting these guidelines, including our own Lana K. Dove and other ECHO participants who may be present today as well. I'd like to thank the DOH TB nurse consultant team whose input and comments informed my comments to you today. Last, I want to thank Jen Huber, an epidemiologist with our program, for her assistance in developing the estimated impacts on person days of isolation. And with that, I'll hand it back to you, Bijan.